All right, but today we're talking PD, AD, MS, and MG. I'm hoping by the end of this talk, you will know what those acronyms mean. Parkinson's disease, Alzheimer's disease, myasthenia gravis, and multiple sclerosis. All right, we're going to talk about those today. And then we're going to really go into the clinical use of the drugs that treat these diseases, which are going to be the dopaminergic drugs and the cholinergic drugs. And we'll talk a little bit about that biology there that would make sense for these diseases. And then we're going to talk nursing interventions, because I feel like when I connect the nursing interventions to the drug, it has more meaning to you. And I think it also kind of helps you keep up with what's important for these exams, right? Because it's not important for you to be the biochemist who knows all of the pathophysiology of these, disease processes to the T, and also like everything you need to know about the drug pharmacokinetics. No, we're going to focus mostly on what it means for a nurse administering this medication to a patient. All right, so hopefully that helps. So we're going to talk a few high alert medications and their antidotes this week. And the goal is to get through all of our slides. That's why I've reduced them this week by about 20 slides or so, with a lot of photos and images embedded there, so that we can get through all the material and stay focused on this week's topic. All right. So hopefully these are the goals. By the end of the day, you will be able to at least connect these meds with this pathophysiology. All right. So connecting these meds with these diseases. All righty. Yeah, there's the outline. I think I've kind of set you up for that. We're going to have some active learning case studies and practice questions embedded in here, so that we can see and assess as we go your understanding of what I'm putting down. All right, if you see the bright blue, or I don't know what color this is kind of like an electric blue. If you see that, that means it's a hyperlink, if it's underlined, and you can go over to Merck. Those are for each disease, I gave you the Merck manual link for that, okay? Just so you can, be checking it out while we're talking about this. All right, because we are talking about Parkinson's first. Parkinson's disease is our first interesting neurological disorder. All right, so it is chronic, it is neurodegenerative, meaning that the neurons will progressively degenerate over time. All right, this is a problem of degeneration of the neurons. All right, and anytime you have a breakdown in a cellular structure, the body's gonna let you know in some kind of way that this is happening. All right, and in folks with Parkinson's, they are going to present with what we call the TRAP symptomology. All right, TRAP is T for tremor, R for rigidity, A for akinesia, but that's really bradykinesia. What do you think bradykinesia means? That's word fun time. Slow, something slow, right? Kinesia would refer to movement. Yeah, kinesia. So slow movements. All right, so tremors, rigid muscles, slow movement or a change in movement or the loss of movement, and then postural instability. These individuals are not able to maintain their posture. Okay. All right, it's progressive, and it does involve the destructive of these specifically dopaminergic neurons. All right, so if you had to think of the neurotransmitter of choice with Parkinson's, it's dopamine. Dopamine. All right, so dopamine depletion is going to be a problem for all of us. We all use dopamine. We all fire off or transmit dopamine. We have dopaminergic receptors all over the body. Dopamine is actually one of the happy or one of the good or up neurotransmitters, right? We have dopamine fired off. It's usually connected to like impulses, pleasure, and we'll talk a little bit more in a second about how if you open up those dopaminergic receptors too much, you can get some unwanted side effects. All right. We'll talk about what that actually involve pleasure and desire. All right. So dopamine. All right. So the pathomap for Parkinson's disease would look like a loss of the dopaminergic neurons in the substantia nigra. Now, in this little picture here, substantia nigra is located right here in the brain. So you remember we had all the hypothalamus, and then we have, well, hypothalamus, thalamus, pituitary gland. And right here, there's like a ganglion of cells, right? It's not really a structure, an anatomical structure. It's more like an area, all right, where we have a bunch of neurons that are grouped together to basically manage your dopamine receptors, your dopamine pathways, all right? Nigra. Basal, I'm sorry, substantia nigra. All right, that's a good one to know. All right, so from there, it goes to reducing the dopamine in the basal ganglia. All right, basal ganglia. Again, another little group of cells. All right, we're not talking about an actual structure. We're talking about just an organization of cells that actually make all of this work. All right, so, and this loss of dopamine, right, or loss of dopamine in these important circuits will cause motor changes. All right, and we talked about the bradykinesia, or the slowed movement, the rigidity, where you have muscle rigidity in the patient, and resting tremor, meaning they are sitting there, but they have a tremor, right? They are not, the tremor isn't associated with exertion, all right? It's actually seen on resting, okay? So they might have the tremor, the postural instability, and then there's some non-motor symptoms that are connected to our dopaminergic neurons, all right? That would involve the constipation, all right, or the slowed drying of the GI tract, all right? I like to think about it like that. It's like slowed digestion or slowed food processing. All right. And then REM sleep behavior disorder. REM sleep behavior disorder. So because of this location here next to all of these important structures that basically are the central processing unit of the body, right? You're going to affect those sleep centers. All right. So this is going to be something to consider as well. And then depression. Depression is kind of it covers a lot of behaviors. So we just call it clinical depression in the patient who has Parkinson's disease. So in other words, a patient who is depressed will present flat, generally speaking, right? A flat affect is one where you just aren't seeing the emotion, right? So you'll see an individual, now there might be emotion behind there, but depending on whether or not they're taking medication for the depression, you will often get a patient who isn't necessarily like engaged completely in your conversations. They're flat affect. All right, so there are some fluctuations with Parkinson's disease where sometimes the people seem on there, but then there are other times where they seem like they're flat, gone, not really engaging with you. All right. And then these dyskinesias, because we're going to talk a little bit about how we impact or improve bradykinesia, but the medication itself will cause other dyskinesias. All right. And mental health meds or any kind of meds that will mess around in those brain centers that impact depression, surprisingly are connected also to dyskinesias, right? And you'll see that more in our mental health stuff. All right, so here's a healthy brain. And the areas of interest for Parkinson's disease would be the substantia nigra. Again, it's not a structure, it's more like a ganglion of cells, a grouping of cells that do very important critical functions. I guess they learned this kind of thing over time doing like PET scans, where they would see which areas of the brain light up when they give certain medications or in certain people with diseases, right? So you could see how those areas malfunctioned. And what they see in folks with Parkinson's disease is that they lose or see damage to this area, atrophy to this area, right? And given the rest of the brain possibly looking normal or the tissue looking normal, this is where they find the damage, okay? So the dopaminergic neurons are in the substantia nigra. Okay, and this diagram explains that. All right, so the problem with Parkinson's is that we get an imbalance between the dopamine. Dopamine is like an inhibitory neuron, all right? Whereas acetylcholine is more of an excitatory neuron. We're just talking patho really quickly. You won't be graded on this aspect, right? I just want you to understand, though, the key neurotransmitters here, all right? And kind of what they're doing, because when we go into the pharmacokinetics, it's really going to come down to these receptors being impacted, all right? These are what we're working on to improve or make changes or, cause symptom reduction in patients with PD. All right, so there are different other factors that are contributing to the pathophysiology of PD, including genetic markers. Okay, there are some, I'm sorry, not genetic. Please take that back, wipe that out, because there are disease processes that we'll be talking about today that do have major genetic markers, right? But I don't want to emphasize or overemphasize the genetic connections here. They are here, but it's really environmental factors. Actually, to be honest, we really don't know for sure all of the underpinnings or the understandings around PD pathophysiology. We think that there are factors that environmental factors at play. For example, folks who live on farms and are exposed to pesticides have more prevalence of PD. All right, there's more Parkinson's present there. But we also see that this was something I was looking at and didn't find it in the literature that I was using to research class today, but the flu, right? Before 1918, we never had influenza. It wasn't endemic to our population. But after 1918, flu became something that was just endemic, right? Just like COVID is right now. We never had COVID before. And now we have seasonal COVID, right? Where people get the infection throughout the year. Now, you know how they talk about long COVID, which is like this long lasting symptoms that continue even after the exposure or after the disease process is over? You're still having this. Well, it was thought for a moment that flu had a long flu type of sequela or like continuing of symptoms even after the infection, and Parkinson's disease what came about. Okay, so they thought maybe the common denominator with these folks who actually expressed Parkinson's disease was that they were exposed to influenza at some point in their lives. All right, so that's possible that there's some kind of immunoconnection to like long-term exposure or long-term symptomology after being exposed to a virus. But that's not well supported. But to be honest, neither are a lot of these ideas about what we think causes PD. All right. Well, anyway, that said, there are various components that contribute to this pathology. Lewy body. A Lewy body is like this little, I think I used this graphic here to kind of show you how you got these neurons, but something's happening between these neurons with these little white dots. They could be the Lewy bodies. That's why I thought, maybe that's a good idea to add them in there. Well, not these white dots, these are the bullets. These little areas, these little areas of impact, all right? Because what happens is it's like a little formation of a nodule happens on the neuron and it kills the neuron essentially. And those little formations are called Lewy bodies. Now, Lewy body, I might remember because I see that often. People want to connect Lewy body to Parkinson's disease. And I think that maybe those bodies that contribute to the death of the neuron create and contribute to the spasticity, the rigidity of the muscle, and the tremors. So there's a motor connection in there that's connected to whatever happened with the formation of these Lewy bodies. All right, so how does it look when a patient comes in with Parkinson's disease, right? They may have this specific type of tremor called a pill rolling tremor, where they seem to be doing this. Like they have a pill between their fingers and they're just rolling it all day, rolling it, pill rolling. Autonomic almost. It's like automatic. They're not trying to do that. It's like actually just a common tremor seen in the patients. Cog will rigidity, right? Where you might have the patient like make a robotic type of movement, and it's or even like a stopping and starting a movement again. It's kind of weird to see this. And the shuffling gait. Shuffling meaning they don't pick their feet up. They kind of just walk like this. Again, it's a dyskinesia. They cannot control it. It is a cardinal sign of PD. All right. So bradykinesia is the slowing down of movements, and that eventually and also connects to speech as well. So you might see them, it's not your typical aging where you see slowing or quieting of the speech. It's more like a stutter, right? Difficulty starting what it is you want to say. All right. And then with that too, you might also see some like slurring or, inability to be understood. All right. So the non-motor symptoms can be just as impactful as the motor symptoms because of the autonomic nerve connections. Okay. So constipation, that's a movement of a type, right? Bowel movements are a movement of a type, but they are autonomic, right? You don't control that as much as the brain does. So with that said, orthostatic hypotension, constipation, mood changes, cognitive changes are all symptomology connected to PD that are not necessarily motor. So I shoved in here this little graphic that for the graphic folks who would rather see this expressed alongside the representative graphics. So the central responses are represented by the little brain here. The airway responses, when you're talking about muscular bradykinesia, that's autonomic and motor, then yeah, you could also have some upper airway issues, right? Things that involve like the diaphragm and ventilation control, right? Because this is connected to the muscles. Muscular weakness, intestinal, which again, these are muscles, these are smooth muscles, autonomic muscles, but they are still muscles and impacted by Parkinson's disease. All right, you might even see the eyes, and I don't want you to get this confused with myasthenia gravis because it's really a lot with the eyes with myasthenia gravis. But the eyes, you might see this thing called blepharospasm. Bleph. I've learned a lot about that word, bleph, like eyelids, like eyelid surgery where people get that nice little eyelid lift. It's called a blepharectomy or something like that. Anyway, it's like the removal of the extra skin on the eyelid. It's like an aesthetic procedure. But here, bleph may help you kind of keep up with that. Bleph is referring to the eyelids, where the eyelids are forced closed. This is more of the muscle, right? Where they're forced closed. So you're looking at a person who has an affect that's relatively flat. They're shuffling in their gait, all right? Their eyes are forced shut, all right? And they're spastic or rigid in their movement. So they look a particular way, all right? And then they may have a tremor. They're likely to have a tremor. They might be sweaty. These are just some of the autonomic and motor changes that you'll see. So just to summarize, motor changes, tremor at rest, muscle rigidity, bradykinesia, postural instability. Non-motor changes might be depression, cognitive impairment, constipation, sleep disorders. All right. So in order to treat this comprehensively, we have to recognize that the changes will happen in both these motor and non-motor ways. All right. So we have treatment. We're going to talk treatment now. All right. For one thing, there is no cure. We're just treating symptoms. There is no cure to Parkinson's. I have this little feeling, the public health nurse in me really thinks that Parkinson's will continue to show up as this non-specific symptomology and that there's no cure for, as long as we aren't are or are not making those connections to maybe viral exposures. All right. Because viruses can't be treated either, can they? There's no real target or good treatment for that. You treat the symptomology. I don't know. That's just me. It's not going to be on your test or anything, but I feel like we need to make that virus PD connection, and that might help with thinking about how we're going to treat it. But that said, the treatment approach is to replenish dopamine, right? Because there's dopamine damage to the dopamine centers, right? So there's a reduced amount of dopamine. Who knew dopamine was so connected to so many muscular functions? But that said, the treatment is to give more dopamine, all right? Or to present medications that mimic dopamine, which is essentially giving more dopamine. Or what we could do is reduce acetylcholine, all right? Because as I mentioned earlier, it's the acetylcholine that has an excitatory effect in the basal ganglia, thus stimulating the production of the neurons, versus the dopamine, which kind of stops or blocks the development of these neurons. Okay, so the imbalance is the problem. The imbalance is the problem. So the treatment, it makes sense that we would want to replenish dopamine, mimic dopamine, or reduce the effect of acetylcholine. All right, so hitting it those ways. Non-pharmacologically speaking, we can encourage more exercise in a patient who has rigidity or tremors. Exercise would actually improve that. Nutrition, right? Watching out for what, and you'll see some of the food connections in a moment. And then physical therapy, of course, physical therapy. All right, so levodopa, carbidopa, levodopa, carbidopa. There's a movie about Parkinson's, and that's where I learned about levodopa. I was like a kid when that movie came out, and I was like, oh, fascinating. Can I remember the name of it? I should, because the patient did something this is where I learned about the behaviors that they do. Um, oh, I got to think about it. Anyway, at one point, the patient's not moving, they're being super flat, and then someone comes in, some scientist or whatever comes in, throws the patient a ball right out of the blue. The patient catches the ball, even though they're like really flat and seem disconnected. Out of the blue, they just caught the ball that was coming towards them, which I think proved that there was a stop and start effect um, to PD. But it also kind of led to the development of the drugs that we have now first line for the treatment of PD. And I think that movie was just about the guy who created levodopa, carbidopa. All right, it works in two different ways. All right, so levodopa crosses the blood-brain barrier. This is really hard to do, like to have a drug that crosses the blood-brain barrier. All right, because we got to get to the dopamine receptors in the substantia nigra, right? So we need a drug that will go over there. And so carbidopa, so levodopa gets over there, gets to the dopamine, right? Receptors. Carbidopa is also doing a job by inhibiting the peripheral, precursor to the peripheral precursor to acetylcholine. Okay. So I'm using this to describe how these drugs are a pair. They come together, right? Because one is the prodrug that's getting across the brain barrier where it can become the drug, right? And then the other one is doing an inhibitory effect to reduce. So it's like one thing is increasing the dopamine while the other one is kind of managing the dopamine. All right. It increases the availability of dopamine in the central nervous system. And it also does this thing with nausea and vomiting. It decreases nausea and vomiting. But we don't give it to treat nausea and vomiting, but it's helping that patient who will actually have adverse effects of nausea and vomiting with reducing it. All right. So the whole therapeutic effect profile of levodopa carbidopa is to improve the rigidity and the dyskinesia or bradykinesia. And it's not really doing much for the postural instability, but it is helping the rigidity piece. Okay. So I know it sounds very counterintuitive to have something that reduces nausea and vomiting have the adverse effect of nausea and vomiting, but that is true with levodopa, carbidopa. And again, with these high risk, high stakes drugs, we usually have to make sure we're getting them in a narrow therapeutic index, right? Because we, don't want to create an adverse effect that we're hoping to treat. All right, orthostatic hypotension. Again, when we're crossing the blood-brain barrier, you're up in the autonomic region, right? Messing around with the central nervous system, then you're going to expect central nervous system side effects, okay? So that's why we would get orthostatic hypotension, where the patient sitting fine, blood pressure fine, and the moment they stand, the blood pressure goes through the bottom of the floor, okay? Not good. That could result in fainting spells, dizziness. Okay, so we definitely want to keep an eye on that. Arrhythmias are rare, but that's a possible adverse effect, not side effect. I hope you guys are making the connections with side effects. Side effects are kind of unavoidable, things we teach about. Adverse effects, we tell the patient, call your provider, okay? Adverse means that's not good. We need to address that. Okay. Hallucinations, right? Because again, we don't know what we're doing completely up there in the brain around the hypothalamus and all those other places where autonomic functions are happening. So we get these unintended adverse effects sometimes that we did not plan for. So what we do, especially when the treatment kind of outweighs or the disease like symptomology demands that we do something to treat this patient, we have to kind of teach about the potential side effects and try to help that patient uh, with addressing those. All right. And then the wearing off. There's this thing called wearing off with levodopa, carbidopa, where, and it may explain why the patient has this like on-off personality thing, because when it wears off, it kind of just goes right back to the state that you were in before. It's kind of like ADHD meds, where they kind of work in the time, in the moment, but it's like it's not long after they just kind of completely are out of your system and you have to take them again. All right. It's that kind of thing. So, and when it wears off, it wears off. You can feel the patient, you can see it in the patient that it's just not like a nice little profile where it's wearing off and you can start giving the next medicine to work it up so that you can experience like even symptomology. It really does like wear off, where the patient again goes back to being flat. The movie's really cool too, because the patient is flat the whole movie and then they start taking this medication and you see them like come alive, see more a more responsive personality. Okay. So yeah, there are some contraindications here with levodopa carbidopa. All right, but let's focus on these nursing interventions and patient education. Do not abruptly stop these meds. You would think that's just the rule for all meds, but these meds that get into or cross the blood-brain barrier or impact or affect our central nervous system, we can't stop them abruptly because usually they're connected with our sleep patterns, our eating patterns, our affect, our personality. We can't abruptly stop these, okay? Now, because of orthostatic hypotension, as nurses, whenever you guys see this, I want you to immediately think safety. I have to think about my patient's safety, right? I want them to rise slowly, put them on fall precautions, educate them as you're walking around them, to inform them of the potential pitfalls that exist in the environment, okay? Orthostatic hypotension. High protein meals, you want to space those away from these levodopa, carbidopa doses. I was looking this up, like why? I thought it might have something to do with like protein synthesis, and I couldn't really find anything that looked like that. We have just learned over time that high protein meals, along with the medication, results in unintended side effects. All right, it makes the medication less effective and you get unintended side effects. All right, and then we teach the patient to report unintended side effects, all right, like hallucinations or their dyskinesias, right, these involuntary movements, because those movements and dyskinesias are going to be improved most with the medication. So if a patient ever reports continued symptomology, that kind of tells you that the medication therapy isn't working. All right, so you want them to report that. We keep an eye on them for hypotension. We review the drug interactions, and you better believe there are some drug interactions with these drugs we'll be talking about today. Lots of them. All right, and usually it's the medication. The antipsychotics are problematic, and these MAOIs, you basically can't do anything if you're on an MAOI, right? So it makes sense. That's always a good choice to pick if you're ever wondering about contraindications or drug interactions. MAOIs don't play well in the sandbox with anything. All right, so administer with food, but not too much, right? A little food. Because if you think, okay, we ought to always give this with food, you might forget that high protein meals are problems. All right. So a low protein meal or snack at the time that you're giving levodopa, carbidopa to reduce the nausea and vomiting. Okay. That comes along with this medication. All right. And then we monitor the blood pressure, of course, educate on position changes to prevent falls. Yes. And here's something else very important. Do not crush these. Don't crush ever any extended release tablet. Okay. How about I just say that? And how do they look? They might have XR in the formulary. Okay. Or ER. All right. Or XR, EXR. Do not crush them. It's just a wrong question answer on an NCLEX question or a course test question. It's just trying to suck you in there to try to get you to crush an extended release. You never do it. All right. It will create problems. And now the reason it exists, these extended release tablets are usually because of the pharmacologic profile that we were mentioning before, like where drug wears off, patient stops getting the impact of the drug. They have this start-stop effect, right? But when we give them the extended release tablets, they can have a profile that looks a little bit more like, the patient is actually receiving therapeutic dose throughout the day. So we want that. So a good way not to cause a spike is not to crush those extended release tablets. All right. So the pharmacology around these other drugs that we use for PD besides levodopa carbidopa would be to dopamine agonists, right? Would be to what? If it's a dopamine agonist, what is it going to do? Yes, absolutely. So when we see agonists, we know that it's helping it to do the thing more. Antagonists are somehow blocking or inhibiting. All right, so dopamine agonists makes sense, right? Because we actually need more dopamine because people with Parkinson's have reduced dopamine, right? So what do? We stimulate dopamine receptors D2 and D3, and that produces more dopamine. Yay, right? That's a good thing. So it's used in early Parkinson's to um, as its own therapy, or it can be used alongside levodopa to kind of smooth out some of those motor issues going on with the patient. All right. Nausea vomiting is just uniquely connected to Parkinson's disease. So think of it as an adverse effect. All right. And of course, we have our orthostatics as well. Our orthostatics. All right. So we want to check for those things and monitor. This thing called sleep attacks. I'm like, man, maybe I should take that med so that I can have a random sleep attack in the middle of the day. But it's not funny. It's not cute. I mean, the person is literally talking to you and then they just boom, they're asleep. They're just asleep. And it's an attack of sleep. It's not desired. It is not healthy. It is not safe. All right. Imagine driving your car and you have a sleep attack. Okay. So that is an adverse effect, not a side effect, an adverse effect. And we need them to report that. Unfortunately, again, we know what part of the brain we're in. We're in a place where we may not be able to control everything that's happening in there. They're ganglia, they're cells that are all overlapping with one another. Hallucinations can happen. Okay. And then this last adverse effect is very interesting because I imagine it happening in people who are possibly older adults, right? And suddenly you see them having impulse control issues. All right, gambling is highly seen in these folks taking dopamine agonists. And what's weird about gambling is that it too is a dopamine agonist, right? So it's encouraging you, because gambling and other pleasure activities like that, addictive activities, are firing off that dopamine, right? And dopamine we want dopamine to be firing off, right? It's a good thing when it's good. But we also have receptors or we have neurotransmitters that reduce dopamine just because we need to keep it in control, right? There's a reason we experience all these neurotransmitters. But if we stimulate too much dopamine, we may give the person impulse control issues, right? And often what we see is hypersexuality and gambling in folks taking dopamine agonists. I'm just saying, imagine seeing that in this gentleman here, where he's probably been on a fixed income for a while and now he's risking it all to gamble because he absolutely just can't control that impulse, right? And hypersexuality. Imagine your grandmother suddenly becoming hypersexual. All right. So a lot of the times we're looking at folks who are older. So it should be relatively easy to see that something's not right. All right. So we can screen for these. Excuse me. We can screen for this and for all of these adverse effects and ask how the patient's doing when we are seeing them on return visits. Excuse me. So remember this nausea, guys. Remember dizziness. These are the symptoms associated with PD, okay? PD treatment. Sleep attacks. All right, so you see a question might have like, Mr. Jones has had Parkinson's and he started therapy for Parkinson's that include dopamine agonists, right? And, or they may give you the name, pramipexole, okay, ropinirole, or rotijonel. Oh, that's not a L right there. All right, dopamine agonists. I don't have a good way to remember those either. The OLEs don't hold up over here, but OLE could help. But there are other drugs that end in OLE, so you may just want to connect those. All right, so ask the patient about what's going on in your life, and if their family members are like, suddenly he's taken to online gambling and he's wiping out our accounts. We go, okay, that's an actual effect of the medication, and we may want to change his therapy because it's not helping. All right, adjust dose maybe. All right, so we start at low doses with these medications. Makes sense, right? Makes sense to start at a low dose and titrate. And remember that word titrate is to increase or decrease the dose based on the symptoms, all right? Based on the patient's presentation, not on the order itself, right? The order will tell you to, how to administer the drug according to the symptoms, but know that it's really more or less about slowing down or increasing the drug according to the patient's response, okay? So that's just so that we can keep a patient from falling due to postural hypotension or orthostatic hypotension, or falling asleep and having sleep attacks from the medication giving them sleep issues. Also hallucinations, you can always ask about them. All right, so now we are going on to another type of drug for PD. I want you guys to be able to see this. All right, it's called the MAO-B, not MAO-I, MAO-B inhibitors. Selegiline, razagiline, safenamide, all right? I think these will hold up. The alines, I think they'll hold up pretty well as MAO-B inhibitors and a good suffix to rely on. All right. That said, so these actually inhibit the breakdown of dopamine. All right. We want dopamine, but we want it in levels that are not too much, right? Because we don't want our patient gambling out of the blue. But at the same time, we need a nice balance, right? So we inhibit dopamine breakdown in the brain, right, which is MAO-B receptors, all right? So we inhibit that, which then gives us more dopamine at the synapse, all right? And do I have a nerve here? Let's see if I can show you the synapse. No. All right. I have other pictures that have the nerve. We can see the synapse and the neurotransmitter crossing the synapse, but essentially creating more neurotransmitter at the synapse or the gap of the little neuron is what it's about here, right? Creating more dopamine. All right, it makes more dopamine available, which then impacts the patient in a positive way. All right, but the adverse effects are just a little different, all right? You don't see hypotension, you see hypertension with the MAO-B inhibitors, all right? Selegiline. So you get a question that says, patients taking selegiline, you know it's an MAO-B inhibitor, don't think hypotension, think hypertension as a precaution, okay? And hypertension with tyramine-containing foods. We've already talked about tyramine, have we not? We've talked about tyramine before, and we were talking about the use of it with certain types of drugs, right? And they were psych meds for the most part. Now, tyramine, do y'all remember the tyramine-containing foods? Cheese is one. That's what I always think, right? So I start thinking of aged foods. So you get your meats, your delis, your alcohol, things that are aged. Yes. All right. Well, you don't want to do those foods with MAO-B inhibitors either. Okay. They will cause hypertensive crisis, not hypo, hyper. So much so that the person could stroke, all right, or have a stroke or experience a hypertensive crisis where a person who's not at risk for stroke suddenly has spikes in their blood pressures that are in the 3 digits over 3 digits. Okay. That's a crisis. So we don't want that in our patients taking MAO-B inhibitors. I don't like MAO-Is or MAO-Bs. Okay. They're problematic. So with that said, you want to look out for those adverse effects, and you don't want to mix hypo with hyper. All right. They will give you insomnia as well. Parkinson's people have a trouble sleeping. They're going to have sleep issues, okay? And a lot of times they're related to the treatment. So this patient on selegiline for Parkinson's is likely having sleep issues. So we're asking about that and inquiring. Serotonin syndrome as well. I know we're talking about dopamine, but there is a risk of serotonin syndrome, right? If you take MAO-Bs with SSRIs, SNRIs, TCAs, all right? We've already done those, but the point is, the problems with MAO-Bs happen often when you're mixing them with other drugs, right? Or foods containing tyramine, okay? So it's just it doesn't play well in the sandbox, and you need to know that. All right, it will elevate the blood pressure, the sulfonamide, all right, and insomnia is usually connected to selegiline. All right, so serotonergic drugs are the SSRIs, SNRIs, TCAs. So you need to do a medication reconciliation. This is when the nurse takes all of the medications the patient's taking, and the patient has told you verbally, I'm on these medications, or they've brought over a sample of all their medications in a bag, and you do the reconciliation there. And this is where you will realize, especially MedRec happens alongside software, right? Where the software itself will say, oh, these two drugs don't relate well to one another. And then you have the opportunity to have the patient or find the doc and have it removed. All right. So that definitely is worth it with the MAO-Bs. All right. More on the side effects: nausea, insomnia, selegiline, headaches. Avoiding tyramine-rich foods. It says only at high doses, like if you're at super high doses of the MAO-B, but let's just avoid tyramine-rich foods altogether until we figure out how we're going to regulate this drug. All right. And remember, tyramine causes hypertensive and not hypotensive crisis. And then I hope you don't confuse serotonin with dopamine. We have lots of neurotransmitters, but that when you mix MAO-Bs or add MAO-Bs to a person who has depression, that's not that weird, that a person in Parkinson's has depression, they might be taking SSRIs or SNRIs. Well, if they're taking this MAO-B inhibitor for as well, they're going to be at the risk for serotonin syndrome. Okay, and we don't want that. All right, so ensure proper washout periods mean that if that patient was depressed or they thought they were treating depression, right, and they didn't know they had Parkinson's, and now we realize they have Parkinson's, so we need to start treating this Parkinson's, right? We need to ensure washout of the SSRIs, okay? So don't start, and SSRIs take a moment to get off. So we don't start the MAO-Bs. That's why medication reconciliation is important. Okay, it's your way of making sure that things that might have fallen through the gaps or through the cracks there were caught, and we're not putting our patients at even more risk for other bad side effects. All right, so just doubling back on the adverse effects of levodopa carbidopa, okay, nausea, vomiting, orthostatic hypotension, dizziness, all right, long-term dyskinesias or involuntary movements. Again, long-term usage of levodopa carbidopa can lead to that. All right, and I didn't mention this before, but narrow angle glaucoma, if a person has that, they should not be taking levodopa carbidopa because there is an impact on the glaucoma if they're on that, okay? Or they may have to have the glaucoma treated before they're able to take the levodopa carbidopa. All right, I don't think that would show up on a question though, really. I mean, it's just interesting and nice to know, and it's also something you want to educate your patient about. All right, other medications the patient with PD may take, right? A Parkinson's patient may also be on anticholinergics for tremor. Anticholinergics, we're going to talk more about those in a minute, aren't the first line treatment for Parkinson's disease, all right? As a matter of fact, yeah, it's not. So know that has, that we proceed with caution in giving anticholinergics because of the cognitive side effects. But I guess if the patient is younger and they are just experiencing tremor, they can take benzotropine, well known, or really one of the only anticholinergics. All right, COMT inhibitors like entacapone, all right, will prolong the levodopa effect, so they may give that along with as an adjunct therapy with levodopa, all right, to help it do what it does. All right, and yeah, it has some nursing indications here to monitor the patient for diarrhea and urine discoloration. I think it turns the urine orange, these COMT inhibitors. All right, but that on and off, wearing off phenomena, we definitely want to create or help the patient create a medication protocol that allows them to be able to have a baseline profile that's relatively stable, right? We don't want this wearing off phenomena happening, right? Just imagine that you're on a medication and it works well for you, so you're able to work and continue doing things in your life, but when it wears off, it wears all the way off, and everybody in your office is exposed to like your worst symptoms, right? So management of those medications and getting the adjuncts together really will help that patient be able to have a more sustainable life or lifestyle. All right, non-pharmacologically, I think we mentioned these already. I don't want to be redundant, but it makes sense, right? If a patient has safety issues around movement, that we're going to think about fall prevention, home safety, right? And think about what happens at the wear-off phase as well, that potential for that, and how you might support the patient when or if the medication isn't doing what it should be doing. Kind of like seizure medications. You got to keep going back until you're on, a stable regimen, okay, that works for you. All right. Yeah, I have a little repetition here. So just more of the same. This is a slide from or a graphic from your textbook. And I chose it because it will show the different ways we can increase brain dopamine, right? Levodopa, and it describes how levodopa works, carbidopa and how it connects to levodopa to increase brain dopamine, benzotropine, how it works to increase brain dopamine. Memantine, I didn't talk about that one. I did talk a little bit about indicapone and then selegiline. So all of these are trying to help a Parkinson's patient increase their dopamine, right, by targeting those different pathways. All right, so now we move on to Alzheimer's disease. Alzheimer's is it's a very interesting topic to have in with these other topics. I do like the Merck manual though. It does give you a chance or opportunity to kind of go off onto another little tangent if you wanted to. For example, looking at dementia with the Lewy bodies and what's going on there, that could be helpful. I thought I had a graphic here. I didn't have too many cool graphics for Alzheimer's disease. Despite searching for them. But I just wanted you to know that there's your link and that your link leads to, well, lecture slide. Okay. Okay. All right. So Alzheimer's disease. It is the most common cause of dementia, of all of the different types of dementia. It's the most common one. It is progressive. And what do I mean when I say a progressive disease? Yeah, it just gets worse and worse. There's no cure, and the disease itself progresses. All right, so progressive decline. So if you know a person with dementia or with Alzheimer's, then you know every day that you see them that that's the best you're going to see of them, that the next day they will just continue their decline, okay? Which is so stressful and for a caregiver and so life-changing, for caregivers. That's why with Alzheimer's, we talk a lot about care of the caregiver with Alzheimer's. Yeah, because there are two people usually going through this, right? That live in caregiver. That said, beta amyloid plaques, that's what form on the brain, right? And they create these neurofibrillary tangles. Of course, those would be things that we'd have to view on like a PET scan. And that causes neurons to be lost, okay? We just lose the whole neuron, all right? So whereas before we were looking at some type of loss of a neurotransmitter, this is the damage to the neuron. With PD, we did see that Lewy bodies could also be contributing to the loss or the damage of that nerve, because the Lewy bodies are these little, I don't know, nodules, granules, something on the actual nerve causing the damage. Well, here we do have an anatomical thing, these plaques on the brain. All right, so the pathology is the presence of these plaques, and they create these tangles, and we lose nerve function. All right. There's also a key neurotransmitter, acetylcholine, and glutamate. All right. Again, I don't want to get too deep into the pathophysiology where you're just learning a bunch of terms, but I do think you do want to make those connections between the right transmitter with the right disease. All right. But it's a deficit of one transmitter, right? And possibly too much excitation of another. All right. So sometimes we're inhibiting things, and sometimes these disease processes cause things to over excite. And when we get too much of anything, there's a chance for toxicity. All right. So excitotoxicity is referring to the glutamate protein, and this glutamate might be connected to Alzheimer's disease. Why do I mention these? Because they will lead to the therapies, right? Sometimes we have actual substances that are present that shouldn't be there. Other times we have neurotransmitters doing too much or too little of their job and needing to be enhanced or inhibited, okay? All right, so Alzheimer's disease, usually greater than 65 in age, all right? There is a genetic component. We have found the allele on the gene and the mutation that causes Alzheimer's disease, okay? Whenever we mention genetics and they actually know the allele, that means the potential for targeted gene therapy is there. So I hold out hope that there will be the opportunity for gene therapy to heal individuals with Alzheimer's disease by going in, targeting the gene, turning it on or off or whatever they do, and possibly causing healing. All right, but that said, knowing the genetic marker has not necessarily led us to a targeted treatment, but we do know the connection is there. All right, there are some cardiovascular risk factors associated with Alzheimer's disease. Cholesterol, high cholesterol, obesity. I don't think they're clear connections, but there are some cardiovascular connections that have been noticed. All right, head trauma. Perhaps the individual had trauma at some point, and then Down syndrome is also associated as a risk factor. All right, that was new to me. I did not know that. I never knew that Down syndrome had that Alzheimer's connection, which is really tough on caregivers. You know, I can just imagine that you've been caring for your Down syndrome, probably total care loved one, and then they convert over to Alzheimer's disease. You know, that's tough. All right, so the early symptoms might be, and the early symptoms might happen is when the person's still quite young and not necessarily at the age of 65, right? Short-term memory loss, just little losses of memory. You know, it makes everyone think, oh, maybe I'm going to have Alzheimer's. But what we do know is that when you go back and look at individuals who have Alzheimer's, what you see when you go back in time is that they were having little memory gaps all along the way, probably for decades back, that were relatively unexplainable. All right. But there are some memory issues that happen with age. Like it takes us longer to remember things, or we never really quite catch the name of what it was that we were looking for. But this short-term memory loss is often seen early in the disease process. Language difficulties, where there's an individual who may want to say a certain term, but they just kind of end up mashing together. Like say they like not being able to find the word. Or when you want to say the word, you thought you said it correctly, but what it sounded like to the hearer was mishmash, right? It did not come out making much sense. All right. So language difficulties. Also spatial, like being aware of your spatial environment and being able to kind of occupy it correctly without really kind of, and it has to do with the ultimate like progressive nature of the diseases that they may experience in the future, like dementia. And dementia can often have that patient be present in a space that they aren't actually in, right? There's like almost like a psychosis where the individual believes that they are somewhere that they are not, right? So there are some visual spatial issues in there. All right. And then behavioral changes happen over time where the people cannot perform their own ADLs. They don't remember to eat. They don't want to eat. They don't sleep, or they begin to wander, you know, or they begin to feel that they are in another time. They don't believe or feel that they are in the current day or in the current scenario or in reality. All right. So it's not seen as a mental health issue, though. It is seen as a neurobiological issue. All right. And in late stage severe dementia, these people can be total care, like absolutely unable to do anything for themselves. And it can be what ultimately leads to their demise as a cause of death. All right, so healthy neuron, an Alzheimer's neuron, okay? Amyloid plaques. So just say a lot of times we're giving a name to something that cannot easily be visualized, but let's say these amyloid plaques are present on the neuron, they destroy the neuron, all right? You will also notice that an Alzheimer's brain is more atrophied than a healthy brain. And by atrophied, I mean that it's reduced in size in the gyri and the sulci, all right? You will see that there's some reduction in the size, right? Ventricles may be larger, right, with more space in them. And look, there's complete atrophy here, loss compared to that side of the brain, complete loss of brain. So what that feels like to a person who has Alzheimer's is they don't know that it's no longer there. They just can't find it. They just cannot find what it is they're looking for, whether it's a term, or expression, a memory, a thought. It's very difficult to find if we've lost brain matter. So something about these plaques literally eat away at the brain matter. Yes, and it's quite devastating. All right, so the stages would be mild, moderate, severe. All right, in the mild phase, we might see a person who has a memory lapse, are not able to do something complex like go over there, pick up that ball, walk back over here and bring me this, bring me the ball. That might be overly complex for them, all right, where they might lose their way on the way over there, right? They may not ever really make it there, or they get it there and they turn around and they look at you and they start up a conversation. It has nothing to do with the assignment that you were looking to do, all right? So difficulty with these complex tasks, subtle personality changes. In other words, are they being weird? Right now. But that being said, it impaired judgment, problems with agitation, those, may be signs of moderate dementia that again get lost or missed often, if you're not a close loved one and can notice subtle personality changes or difficulty with tasks, it can be difficult to stage it. Okay. At the severe stages, though, we have a loss of language. People do not recognize their family members. They lose their motor skills. They're totally dependent on their caregivers. So it's not just a matter of wandering, that progresses, this disease progresses to severe stages that can be quite, can bring about the patient's death. All right. So what do we give patients with Alzheimer's disease? Cholinesterase. Cholinesterase is another one of our neurotransmitters inhibitors. All right, we want to inhibit the production of cholinesterase. This one's popular here. All right, Donepezil. This one you'll see the most. You'll also see rivastigmine. The ones that end in stigmine, all right, are a class of 80 drugs. They also treat another medication, another situation too. So we'll talk about that a little bit more in the future slides. All right, but the whole idea is we want to inhibit the breakdown of cholinesterase or acetylcholine. All right, cholinesterase inhibitors inhibit acetylcholine breakdown. All right, the most cognitive functional benefit is by inhibiting acetylcholine. Okay. All right, here we go again with nausea, vomiting, diarrhea. That's what NVD stand for. All right, these are GI effects, and they primarily, you're going to see these with our medications that are involving acetylcholine, cholinesterase, right? Because they're cholinergic drugs. Cholinergic drugs typically have some kind of connection to nausea, vomiting, diarrhea. Okay, cholinergic drugs. Anorexia, weight loss, I would connect there for sure. Bradycardia and syncope. These folks would be on fall risk. And here's an interesting one. Insomnia, vivid dreams. Vivid dreams. Now, a patient with Alzheimer's experiencing dementia, having a vivid dream, that's an adverse effect. All right. We may not want to excite, upset, disturb them in an already demented state. All right. So we would definitely want to adjust the drug therapies for people who are experiencing both insomnia and vivid dreams. All right. And this rivastigmine comes into a patch. It comes in a patch format. So we look for skin reactions, not so much the medication not working, but more so the patient not working well with the skin, with the patch, or the patch being irritating to the skin. All right, so contraindications. We are not going to be using cholinesterase inhibitors with a patient who has sick sinus syndrome. All right, because we don't necessarily want to do these autonomic changes or give medications that will cause autonomic changes in a patient already experiencing a certain level of autonomic change, right? Sick sinus syndrome is a chronic, it's a chronic condition. So we don't want our patients who are already experiencing sick sinus syndrome to be on cholinesterase inhibitors. All right, or patients, again, makes sense if you're going to have these adverse effects. You want to use caution in these drugs with people who have risk factors for those adverse effects. All right, never give it to a person who's actively bleeding in their GI or has an ulcer or is at risk for ulcer. All right, it kind of gives you a connection to the nausea, vomiting, and diarrhea piece, the GI effects of this medication. All right, we want to give this medication in the evening because of the insomnia risk, just like those psych meds that we give, at the right time to not contraindicate or not, or to be able to work well with their daily schedules. All right. And with most of these drugs, we're monitoring the heart rate, blood pressure, hydration, fall precautions for everybody. All right. And here is again with the Alzheimer's patients, we have to talk to their caregivers a lot as nurses. We have to keep in contact with their caregivers because they are the ones who are managing the day-to-day, the ADLs, the patient's essential activities, right? So we want to help them with being realistic about what this medication will do for them. All right. It's no cure. There's no cure here. We are basically helping the patient to be more comfortable with all of these terrible symptoms that they experience and may not, because of the nature of dementia, understand, right? They may not even be present enough to understand that they have a progressive disorder that's literally making them, affecting all areas of their life. All right. So adherence to these medications will bring about the best effects, and it's important to teach adverse effects. So I think more importantly than like going through and trying to memorize every single adverse effect, it's more important to know that as a nurse working with a patient who has Alzheimer's, that when you're teaching their caregiver, you're going to be teaching them about what they should be looking out for and that they should be looking out for certain adverse effects. Okay. All right. Those are examples. It's pretty much a summary slide here. So we're inhibiting acetylcholinesterase to increase acetylcholine. All right. So erase or ACE usually connect to enzymes, and enzymes usually cut or clip. They usually have some kind of catalytic role in the synthesis and proliferation of these neurotransmitters. Okay, so if we are trying to stop an enzyme from creating a certain medication, a certain neurotransmitter, to increase that neurotransmitter in certain areas of the brain, then that's our mechanism of action for our cholinesterase inhibitors. Okay. All right. We're going to give these to folks with mild to severe AD. So I would consider this a first line drug. Okay. It will not slow the cognitive decline as well as it will treat those other symptoms. So this is why we reinforce the idea that this is a progressive disease. All right. It's only going to get worse. All right, so I think we have talked about what we're going to monitor for our patients. Makes sense that we will parasympathomimetic means that drugs that imitate or mimic parasympathetic drugs, or drugs that are made to essentially our cholinergic drugs, all right, will kind of have like an agonist effect on all of the side effects, all right? So essentially nausea will be more, vomiting will be more, diarrhea, bradycardia, syncope, all right, are all potential effects or adverse effects that will just be increased that much more when you're taking these cholinergic drugs, okay? Cholinergic drugs are always a problem, right? Because they're going into the brain and they are messing around with our autonomic nervous system. So anytime you see something related to the parasympathetic nervous system, you're going to see certain side effects that are difficult to control, like heart rate, bradycardia, right? Nausea and vomiting, right? And syncope is related to some of the orthostatics. All right, so I really want you guys to connect cholinesterase with cholinergic drugs, and the cholinergic profiles. I have a slide that'll, help us look at the differences and really think about what you might do for that patient. All right, generally it involves education. NMDA receptor agonists, also known as Memantine receptor agonists. The NMDA receptor, we're antagonists. All right, let me get that right. NMDA receptor antagonists. So what is it doing? Working against the receptor for NMDA. All right, NMDA. So it reduces as I mentioned before, we want to inhibit some neurotransmitters, we want to excite others. All right, but with Alzheimer's, glutamate is produced at a level that we might want to reduce. All right, so we can reduce the exotoxicity. All right, so we use this to essentially antagonize this receptor that's a part of the Alzheimer's disease profile. All right, I've probably thrown about 6 of these at you today. All right, but NMDA associate with Alzheimer's because when we're giving that antagonist, it's working against this binder or this receptor to reduce excitotoxicity. All right, we don't want the patient to be toxic or receive a toxic amount of the neurotransmitter that's going to give them all these adverse effects. What are the adverse effects? Dizziness, headache, confusion, constipation. All right. I don't think I have too much more I want to say about NMDA receptors, except that we are going to renal. That's what I wanted to point that out. All right. Of course, as with all the other dementia drugs, we're thinking about fall preventions as well. But renal function, reviewing the renal function, because I'm not going too much into NMDA and the mechanism of action. All right, memantine. All right. So glutamate mediated exotoxicity is what we're trying to impact. So NMDA, glutamate, we're trying to bring about balance in that connection. All right. So we take the NMDA antagonist, memantine, for that. It's very unique in terms of the profile, the pharmacokinetics for it. So it stands out as its own drug class outside of the other 2 drug classes that we already mentioned. But look, the adverse effects are the same, relatively speaking. Hypertension is more of a concern here than hypotension. And it's an adjuvant drug, usually not used as monotherapy on its own. It's usually used along with the big one, the main one, Donepezil. All right, so Did I mention depression before? Our Alzheimer's folks will will not be as depressed as our Parkinson's people are, our Alzheimer's folks, but they will, I would say they could be flat. Flat is kind of like, again, expressionless, but Alzheimer's are different. I mean, they actually may have periods where they're absolutely cogent, right? And there and with you and in the time. But then they might also have these times where they are not with you. They are not in the same year as you. They are not in the same reality as you. And that's fine. But they're not flat either. They're not like depressed about it. They're actually quite excited about where they are. Maybe they're on a mission. I had a great aunt who had Alzheimer's, and she would always had a very important mission with her purse on her arm, and she was absolutely ready to go and meet that mission. And we were just like, okay, so she's like, I've got to go to high school. That she lived in the same town for nearly 100 years almost, and she just had it set on how she needed to go down to the high school because they were having an event at the high school. And she wouldn't have been to high school in over 70 years at that point, but she had her purse on and she was getting ready to go. And so it really makes me think that, it helps me to remember that these folks aren't flat, okay? They're actually excitable, they're moving about, sometimes they're really into what they're doing, and you can get a sense that they believe that they need to be doing this right now, almost like a schizophrenic somewhat, but without all of the energy. Schizophrenics tend to, but schizophrenics actually are a bit flat sometimes, so it's quite possible that you'll see behavioral signs that are atypical. But that being said, they will be given SSRIs, even though they don't technically have depression, all right? Because of its ability to kind of work along with the other medications to give them some antipsychotic relief. Okay, it's short term. We don't want to give them benzodiazepines. Why wouldn't we want to give Alzheimer's patients benzos? What are benzos? Like making them more depressed. So do benzos treat depression particularly? What do they treat? Benzodiazepines. Anxiety? Yeah, right. So anxiety, and you might see an anxious um, Alzheimer's person, right? They might absolutely be showing signs of anxiety. Like they want to get up, but someone's holding them down. Someone's telling them they can't wander, they can't go anywhere. You got to stay here, you got to do this. Let's do this puzzle. But they have a mission they want to do. All right. You think maybe they should get a benzodiazepine. They're anxious, maybe this will help them. No, we don't do that. All right. Maybe if there's something happening and they're really excitable and we need them to be sedated, okay, maybe a benzo makes sense, but it just doesn't work well with all the other pharmacologic interventions that they're receiving. All right. It also doesn't work well with the brain chemistry of an Alzheimer's person to impact their, it's not the trade-off, it's not worth it. Okay, it's not worth it to have them taking benzodiazepines and possibly having contraindication and adverse effects with their other medications, but more likely causing their condition to be worsened instead of improved. All right, and it's a progressive disease, so we want to do what we can to help them be comfortable without putting them at risk. Okay, cognitive stimulation is great for them. So puzzles, Sudoku, like any kind of cognitive stimulation, because they're losing brain cells by the day. I mean, literally losing them. But the brain is so resilient that it has a way of reforming new connections the best it can. All right. So if you keep the puzzles coming, then the brain will be inclined to regenerate and create new neuronal connections. All right. Regenerate is not a good word because we're not going to get new brain tissue. What we're going to get is new neuronal connections so that you can learn. You can still learn and stimulate that brain and keep it active. All right, putting them on a routine. That way we notice if something's not right, if something's off and they're not where they should be. Caregiver education is important, and respite. What is respite? What is respite? We're thinking about the caregiver here. We want to provide respite for the caregiver. Relief, yes, it's absolute relief. So sometimes it comes in the form of letting the caregiver go somewhere while you come in and take care of their patient for a while, right? Or maybe a day or 2 or 3. All right, we got to take care of those caregivers. All right, and we ensure safety as best we can, both in the home and in clinical environments if they come into our clinical environment. All right, I think there's more of the same there. And here's our case study question. All right, so I think I have the answers. Okay, so we have a scenario. We got a patient with moderate Alzheimer's. All right, they're taking Donepezil, the mainline treatment for that, and they're experiencing frequent nightmares. All right, what action should the nurse take regarding medication administration timing? Patient with moderate Alzheimer's taking the first line therapy and they're getting frequent nightmares. What would that nurse do? Yeah, Marissa.
Giving the medication in the morning because that it's anything with Rigidity without insomnia.
Absolutely. That's the answer to that question. Give it in the morning. Okay. That is a good idea. Okay. So vivid dreams, give it in the morning, reduce sleep disturbances. All right. We also should be asking about the GI effects during the daytime and adjust as well. Okay, so whenever you give them the medication, that's when they're going to be having the GI effects. So we want to keep a track of that as well. All right, so now we're moving on to our third disorder.